Hi, my name is Alok Khorana from the Cleveland Clinic in Cleveland, Ohio. The treatment of cancer-associated thrombosis is undergoing a paradigm shift with new data emerging from both randomized clinical trials as well as clinical practice reports as well as registries, all suggesting that the one-size-fits-all approach of low molecular weight heparin monotherapy for 6 months is no longer the best approach for treatment. We have seen data now from 2 large randomized trials as well as multiple registries, and these have led to a new ISTH guidance statement that was published in the JTH last year. These new data are incorporated into the new ISTH guidance, which takes into account the fact that in randomized trials, the rate of recurrent VTE with direct oral anticoagulants, specifically edoxaban and rivaroxaban, are at least as good and maybe even a little bit better than what we see with low molecular weight heparin monotherapy. But this improvement in lowering the risk of recurrent VTE is accompanied by an increased risk of major bleeding, and that increased risk is especially prominent in patients with gastrointestinal cancers. The new ISTH guidance statement, therefore, focuses on the risk of bleeding as the fork at which decisions are made about which agent to use. For patients who are at low risk of bleeding and do not have drug-drug interactions, the ISTH guidance statement suggests using a direct oral agent as first-line option. Whereas for patients who are at a high risk of bleeding or have drug-drug interactions between direct oral agents and systemic cancer therapy, the suggestion is to use low molecular weight heparin monotherapy instead. Thus, we have moved away from a paradigm of one-size-fits-all, low molecular weight heparin monotherapy for everybody, to a paradigm of individualizing treatment, balance on the risk of bleeding, as well as incorporating patient preferences and values, and remembering to look at drug-drug interactions. Thank you.